All right, so hyponatremia part two. This hyponatremia video is just going to focus on the treatment of hyponatremia and the varying degrees of hyponatremia in terms of how bad it can get. And so you guys remember this algorithm that we left off on in the first video, just to familiarize yourself with it. Let's dive right into the treatments, okay? So when you're talking about hyponatremia treatment, the first thing that you want to have in mind is this goal rate. It's very important. And this is essentially about increasing the sodium carefully. When somebody comes in hyponatremic, you don't want to be careless when increasing their sodium levels. And so you want to increase it by 4 to 6 milliequivalents per 24 hours. And that's to a short-term goal of at least 125. You don't want to cross that threshold of 8 milliequivalents per 24 hours because then you start to risk certain, dreaded neurological sequelae, which fall under the umbrella osmotic demyelination syndrome. I'm sure you guys have heard of that. Basically, you have these fluid shifts that can end up impacting the brain where demyelination starts to take place. So we want to avoid that. And so this goal rate is very important. 4 to 6 milliequivalents per 24 hours, a maximum of 8. In somebody who is severely symptomatic and they're hyponatremic, so they're coming in, they're having seizures, they have an altered mental status, they may be somnolent, confused, obtunded, maybe experiencing some weakness in their extremities. You want to go ahead and give them hypertonic saline. So that's 3% sodium chloride, and you want to give it in a bolus form. So 100 milliliter bolus over 10 minutes. And if the symptoms haven't resolved, you want to repeat this. And you can repeat this up to 3 times or until the sodium has increased by about 4 to 6 milliequivalents. If the patient comes in and their sodium is very low, below 120, but they're asymptomatic, they don't have these neurological symptoms, you also want to consider hypertonic saline. And that will usually be, instead of it being a bolus, it's going to be an infusion. And it'll be 15 to 30 milliliters per hour that you're going to infuse at until the sodium is at least 125. The only exception here is going to be polydipsia. And polydipsia, which is basically this like pathological excessive drinking of water. This is a condition that will tend to autocorrect in terms of the hyponatremia. And so you don't want to give them hypertonic saline in addition to that autocorrection, because you could swing them in the direction where they correct way too quickly and start to suffer the symptoms of osmotic demyelination syndrome. And then you have mild to moderate hyponatremia. So mild being 130 to 134, moderate being 120 to 129. You kind of want to treat these patients on an etiology specific basis. Some may need fluid repletion, some may need fluid restriction, some may need diuresis, depending upon what the etiology of the hyponatremia is. And really, fluid restriction is the mainstay of hyponatremia treatment generally. So you'll probably be doing that for most of your hyponatremic patients. The only exception would be obviously your patients with GI losses, where you'd probably want to fluid replete those patients, give them some saline. So let's talk a little bit more about that. So again, fluid restriction is your mainstay of treatment. Each institution will have their number that they're trying to not go above. Found this on UpToDate. Less than 0.8 liters per day is kind of what you want to target. In your hypervolemic patients, so your patients that have an increased total body water, a decreased effective arterial blood volume, right? So this are your congestive heart failure patients, your nephrotic patients, your cirrhotic patients. You want to definitely think about fluid restriction and also diuretics. So in the case of your congestive heart failure patients, your nephrotic patients, you want to think about furosemide for your loop diuretic. And the loop diuretic has two benefits there, all converging towards the same goal of increasing that sodium level, but you get the excess fluid off with the loop diuretics, and then you also block that countercurrent exchange that's happening in the kidneys. And so you essentially decrease the effect of ADH, and you end up essentially peeing out more fluid. And so this is a way to raise the sodium level in these patients here. In your cirrhotic patients, same thing, fluid restriction, although it's not as effective. It's very, very hard to fluid restrict these patients. You want to go ahead and discontinue any antihypertensives they may be on. Apparently, a MAP goal of less than 82, like 82 or less, is associated with worse outcomes in hyponatremic patients who are cirrhotics. So you want to go ahead and try and keep that MAP goal above 82. So DC any antihypertensives. You want to correct any hypokalemia that may be going on. Or potassium is just as osmotically active as sodium. As you give them potassium, it will be exchanged for sodium via that sodium potassium ATPase. And so correcting any hypokalemia is important in this group of patients as well. You want to consider Vaptan. So these are ADH antagonists, or hypertonic saline if these patients are getting worse. In your true hypovolemic patients, these are your patients with GI losses, right? So diarrhea, vomiting. You want to go ahead and again replete that volume, isotonic saline or lactated ringers. These patients will also tend to autocorrect once you essentially take care of the underlying problem. So if they're coming in with vomiting and you put them on ondansetron, Zofran, and they stop vomiting, these patients can correct pretty quickly. And so giving them some desmopressin just so that they don't correct too quickly may be important here. Remember, desmopressin is an ADH analog, is going to help you to essentially retain water. So that's a consideration in this group of patients. Same thing with your euvolemic patients. So the three main causes of euvolemic hyponatremia, adrenal insufficiency, SIADH, hypothyroidism. You want to go ahead and fluid restrict these patients. In the case of adrenal insufficiency, once you give them glucocorticoids, which is what they're going to be missing, they will also tend to autocorrect. The glucocorticoids are actually going to inhibit your ADH release. And so to prevent you, the patient correcting too quickly, you add some desmopressin, which will help you to retain some water. Same thing in the case of SIADH. SIADH has a broad group of etiologies, of sub-etiologies, I would say. So there could be drugs that could be causing this, right? SSRIs or antiepileptic drugs. Nausea could be causing this. Post-surgical pain could be causing this. Once you solve that underlying problem, these patients will also tend to correct. The stimulus for the ADH is no longer there. And so you're no longer going to be retaining fluid. And so you're going to be undergoing a water diuresis. In order to make sure you don't correct your sodium too quickly, you can add on some desmopressin. In addition, fluid restricting these patients is important. Adding on some salt tabs is important for these patients, some urea tabs. In the case where the stimulus for ADH is still there, you haven't been able to treat the underlying cause, throwing on furosemide or Lasix, right? That loop diuretic is important to help suppress the effect of ADH. Okay, so those are all good considerations. And then for hypothyroidism, same thing. You want to fluid restrict these patients, and then you want to replace their thyroid hormone. And once you've done that, they should correct on their own. Primary polydipsia, we kind of talked about that already. Fluid restriction, and then also adding on some desmopressin for them may be important. Tea and toast, right, where you've had a patient, they have very poor nutrition. They're really not consuming anything but these calorie light meals, tea and toast literally, or some, in the case of alcoholics, just beer. You want to slowly introduce solute back into your system, and then you want to consider adding on desmopressin because these patients will also autocorrect pretty quickly. And this is just an example of what osmotic demyelination syndrome is going to look like when it comes to MRIs. So you have a T1 weighted MRI on your left, a T2 weighted MRI on your right. And this is a classic case of central pontine myelinolysis. You can see in the T1 weighted MRI image, you have a hypointensity of the pons centrally. You kind of have that three-pronged appearance. It's a classic sign called the trident sign. You essentially have demyelination of your transverse pontine fibers and sparing of those surrounding or peripheral fibers. And so if you suspect that your patient is having complications of osmotic demyelination syndrome, maybe after treating their hyponatremia, they are now somnolent, or they are now seizing, or they're developing weakness in their extremities, maybe some early stages of quadriplegia or quadriparesis, you want to suspect this, and getting a scan, an MRI may be helpful and may yield something like this, what we're seeing right now. On the T2 weighted image, you're seeing a hyperintensity in the pons. That's what that would look like. And yeah, this is a result of just rapid overcorrection of hyponatremia. All right, guys, so that's what I wanted to add on to the first hyponatremia lecture. Hope y'all enjoyed this. Stay tuned for more cases that you should know prior to entering into your intern year.